Welcome to Podcast UK. In this session, we're talking about Thumb CMCJ arthritis.
Hello and welcome to the Podplast UK session on Thumb CMCJ osteoarthritis. My name is Matt Stone, I'm a plastic surgery registrar in Yorkshire, and today I'm delighted to be joined by Sanjib Majumder. Now, he is a consultant plastic surgeon with a specialist interest in hand surgery, and he works at the Yorkshire Teaching NHS Trust, as well as being the director of the UK National Online Learning Programme for Plastic Surgery. Welcome to you, Mr Majumder, and thank you for joining us.
Yes, thank you very much, Matt. Quite an interesting subject. I've got to add that it's quite a popular topic for FRCS PLAST questions. A fair bit of dogma associated with this topic, and we shall address some of these issues. The management options can generate, shall I say, somewhat spirited debates amongst hand surgeons and can lead to some confusion for trainees. So let's get stuck in, shall we?
Absolutely. Well, as you say, this is an important and common problem, and I'm sure it's something you see frequently in the outpatient clinic. What are the key signs and symptoms when you see these patients that help to point towards a diagnosis?
Well, Matt, the first thing people come and tell you is that they've got pain in their thumb, and a lot of them will actually point at their thumb base. They will say they get pain either at rest or when they're using the hand, typically when they're opening a bottle or when they're doing some gardening, all of that sort of thing. Pain is the most common presentation, isn't it, in terms of symptom. People also sometimes complain of a limited range of movement, a bit of stiffness at the thumb, a weak grip, pinch strength. So when trying to pick things up, they might have a bit of swelling, stiffness at the base, and as I said, loss of function. Those are the key things in terms of the history, really, which is, as you know, for any medical condition, the history is key.
Mm. And then in terms of examination, is there anything particular that you look for?
Following the sort of look, touch and move sort of pattern, you look and you may see swelling at the thumb. You may see something called shouldering, where you get a bit of subluxation of the metacarpal, and you get what some people call a squaring off of that joint. And those are the sort of main examination findings without starting on the provocative tests.
It's interesting you mentioned provocative tests. So one of the things that you read about often in textbooks is the grind test. And I've only seen that done a few times and it always seemed quite painful. Is that something you find useful or is it just painful for patients?
Yeah, so the grind test is something that is been enshrined in the hand surgery literature, hasn't it? And every resident and every consultant will have used it at some point. But people have looked at it, and the sensitivity of the grind test is pretty poor. It maxes out at about 50% of the time. So meaning in 50% of the time, someone will have osteoarthritis and the grind test will not pick it up. Okay, there are far better tests, all of them realistically actually eliciting pain. So simple one is getting the patient to pinch. And if they pinch between the index finger and the thumb, you're essentially loading the CMCJ and they can complain of pain with that. The other thing that people use, which is much better, is something called the traction shift or the subluxation relocation. So as part of the osteoarthritis, you get some degree of subluxation of the thumb base. And by relocating it, reducing it, you can then elicit pain. You can do the lever test, which is again sort of waggling the thumb around. It's important to realize that all of these things, as you said, cause pain. Do warn the patient, do it gently and slowly. And once any pain is elicited, do stop. Don't just keep moving it around till they're yelping and jumping off their seat.
And I know you said that the diagnosis of CMCJ osteoarthritis is often relatively straightforward, but are there any other conditions that can mimic this? And is there anything that's useful to try and differentiate from those?
Yeah, so I mean, the history, as I said, was important. We've got to rule out any injuries. So you can get anything like a scaphoid fracture or injuries to the scapholunate ligament, for instance. So any injuries around there, of course, thumb, MCPJ, UCL injuries can mimic this condition as well. Carpal tunnel can mimic this condition, as can a trigger thumb. Okay, but the most common thing really that you got to rule out it is the curve veins because it's just there now. And the most uncommon thing, but people write it on differential diagnosis, is intersection syndrome.
Obviously, Eaton and Littler, they classified basal thumb arthritis based upon radiological signs. Is that something that you find useful in your practice?
Yeah, well, Eaton and Littler, great doyens of hand surgery, and it is heretical, isn't it, to say that I don't find it useful. But hey, I'm old enough to say I don't find it useful because essentially it's a good classification for the radiological findings. And if you want to use it for academic purposes to compare different radiological grades of osteoarthritis, that's fine. But realistically speaking, what you may find is radiologically a very severe or advanced grade of osteoarthritis according to Eaton Littler classification with very few symptoms and vice versa. So you can have people with very little signs on radiographs, but quite a lot of pain.
No, and it's interesting, like you say, that sometimes you see people with radiographs that look like they should be incredibly painful, and actually, often those patients, when you examine them and talk to them, they're almost asymptomatic.
Yeah, it is very interesting. And that's because the pathophysiology of osteoarthritis is not really bone on bone grinding that we are looking for on radiographs, because that's essentially the main thing you see on radiographs. And it's an inflammatory condition. And because of that, the radiological soft tissue issues which can cause pain the soft tissue issues which can cause pain are not obvious radiologically, but are causing severe symptoms to the patient.
I think, as you say, I've often found it quite difficult to understand the actual pathophysiology going on behind the osteoarthritis. I think it's something often that we don't really understand very well.
Well, you're not alone in not understanding it because we don't actually know what causes arthritis other than when somebody has an injury and they've had an articular surface that's been disrupted. So leaving that group out, most patients will come and say, "Oh, I'm getting arthritis because I'm getting older," and that's not necessarily true. It's almost inevitably an immunologically mediated disease process. And the way I explain it to patients is that if you imagine that you've got the joint fluid, which is there to act as a lubricant for the moving parts of the joint, but also to nourish elements of the joint, the cartilage especially. And if this joint fluid changes, where it starts to not recognize the structures around it as itself, it'll start attacking stuff. So initially, the first stage, what you have is the substance that actually produces the joint fluid, that is the synovium. It starts to become hypertrophic and hyperplastic, so much more of it, and it produces a bit more joint fluid. So you have the first Eaton and Littler stage where you have a widening of the joint, but it's still an inflammatory disease. So whilst radiologically just a mild change, you can get quite a lot of pain with it. Then this fluid starts to attack all the other structures which are not even obvious on an x-ray. So you've got the cartilage, yes, attacks the cartilage. As the cartilage is destroyed, the joint space starts to decrease. And then the bone tries to say, well, hang on, we are being attacked next. We want to sort of try to protect ourselves and retaliate. And it does so by trying to get a bit harder. So you get a subcondylar sclerosis. You get the hardening of the bone, what is known as ebonification, so it becomes like ebony. You can get subchondral cysts appearing as part of this sort of trying to defend itself and also trying to create new bone. But the new bone that the bone creates isn't nice, normal bone. And that's where osteophytes come in. So you have irregular bits of bone. So that's the sort of stuff you see on the x-rays. But the other structures that are around are, well, you've got the joint capsule. And if the joint capsule is being attacked by the fluid, it starts to get weak. And as the joint moves, you can imagine the joint fluid is pushing on the joint capsule, and eventually you get a weak point and you get a herniation. And that's how a ganglion is formed. Not terribly common in CMCJs, but you obviously see them in DIPJ ganglia, for instance. And then the last thing is you've got your volar plate and you've got your collateral ligaments, which when they are attacked and weakened, they do not stabilize the joints as well as they should anymore. And you can get subluxation or even dislocation of the joint. So once you've looked at this as a pathophysiology, if you assume that there's an immune issue to start with, but we don't know that for sure, everything sort of fits into place in terms of the symptoms and the signs, doesn't it?
I mean, as you say, that completely sort of explains the things that you actually see in these patients, doesn't it? Which is really quite interesting. I mean, moving on to management now, obviously, there's a number of non-operative options available to these patients. And I don't know if there's a way you tend to approach this or.
Look, the vast majority of people with osteoarthritis of the thumb will probably never reach a hand surgeon. Most of them will try uh, painkillers, non-steroidal anti-inflammatories, which they either can take orally or some of them attempt to rub it on. Whether that helps or not, or there's a placebo effect, we don't know. People will then go to their GPs and they may get some degree of splintage, which works by immobilizing to some degree or completely the thumb so that you get less pain because there's less movement at an inflamed joint. And then nowadays, the GP services will even go on to administering intra-articular steroid if the other things haven't worked. So in addition to what we have discussed previously, patients can have intra-articular steroids, which can be administered by the GP, or they may come to us and then get that. So essentially, when you first see a patient, you got to find out at what level of their management have they reached you, what has already been tried, and then discuss what other options may be available.
And just, yeah, coming back to splinting that you were talking about, one thing that I've seen that seems to vary quite a lot is whether people use rigid splints or compression gloves. And I've never quite understood why you might favor one over the other.
Well, if you have a rigid splint, then essentially it immobilizes the joint, it decreases the movement. And if you have decreased movement at an inflamed joint, then you get less pain. That's the thinking behind it.
Okay.
But obviously, when you're not moving your thumb, or at least that joint, the CMC joint, which is the most mobile joint in the thumb, it limits your function. So you may want to say, well, actually, we'll compromise and put on something like a compression glove or a semi-rigid splint, which acts by giving some degree of support to the thumb, but also allowing some degree of movement. So it's a halfway house, if you will. And as I tell patients when they're given splints, that it's a suck it and see. You got to try and see what works when, where. So, if they're going to do a bit of gardening, they might want to wear something less rigid, but after the gardening is finished, they might want to rest their thumb and use something more rigid. If you allow patients to make these decisions themselves, they will actually come up with a sensible solution bespoke to them, their hand, and their activities.
And you talked about steroid injections and how helpful they can be for some patients. Practice seems to vary quite a lot from what I've seen and how they're carried out. Do you have any specific thoughts, or what is your practice?
Yeah, so I mean, it's absolutely clear that intra-articular steroid into the thumb CMCJ can help. Obviously, it doesn't help everyone. And for how long it helps and how much it helps is also variable. So I will tell my patients that it's unlikely that the steroid will get rid of your pain completely, but it will take the edge off the pain. And in conjunction with splintage, compression gloves, perhaps some non-steroidals, all of these things act or can act in conjunction to help. Now, in terms of the steroid to use, there isn't one steroid that's better than the other. There's no real evidence to say, hydrocortisone is better than using, triamcinolone, and that 10 milligrams per mil, which is at quartile, is any better or worse than Kenalog, which is triamcinolone 40 milligrams per mil. What has been shown is that you want to accurately put the steroid into the thumb CMCJ. And that can sometimes be difficult if you've had quite an advanced arthritis where the joint space is not only reduced, but you've got osteophytes around it, you've got a bit of subluxation. So you're trying to navigate a straight needle into quite a tortuous path into a small cavity. And so in these situations, certainly ultrasound guided steroid injections can be very useful because you're doing it rather than doing it blindly, you're doing it under direct vision, so to speak, or indirect vision, so to speak.
And so with the steroids, are there any side effects or disadvantages that you ever find?
Yeah, so Obviously, you want to put it into the right place. As I said, on occasion, we will get patients who've had a blindly administered steroid, and people haven't aspirated when they're putting it in. The steroid goes into the radial artery, which is not a million miles away from the thumb CMCJ, as you know. So one has to be like every other procedure. You've got to do it carefully, make sure you aspirate before you inject and re-aspirate after you put half the fluid in. I tend to use 10 milligrams of triamcinolone, which is 1 ml. I tend to use it without any local anesthetic. I know some people like to use local anesthetic. I don't actually see the point of it particularly. The other thing you've got to tell patients if they're diabetic that their blood sugars may actually go up for a few days after the steroid injection, but I do warn them that it won't make them run faster. It's only a tiny bit. You can get some thinning of the overlying skin and some hypopigmentation. So all of these things are part of an informed consent process that you've got to tell patients really prior to doing what is an invasive procedure.
And obviously, for most patients, we're expecting this is going to be a transient benefit. Is there a limit to how many times you may offer steroid injections, and what dictates this if that's the case?
So that's a really good question because a lot of patients actually ask that and say, oh, we've been told by our GPs that we can only have it twice or 3 times. That's not really so. I have patients who've had steroids, intermittently for years because they don't want to proceed to a surgical intervention. They find that the steroids help them, and that's absolutely fine. It's only a tiny bit. It's not going to give them any sort of systemic issues per se, other than the little transient blood sugar being raised. The advice really, however, is that you shouldn't be injecting it more than every 10 to 12 weeks, more often than that. I'm not sure there's a huge amount of evidence about that, but that's very much conventional wisdom and advice.
And we've talked a lot now about non-operative options, but I guess we're all surgeons, and one of the things we're interested in is the operative options. How do you approach operations for these patients?
Yeah, so essentially, the options are a trapeziectomy, either a complete trapeziectomy or a partial trapeziectomy, plus or minus some sort of suspension procedure, or using a joint replacement. So if I may just elaborate that on a bit, yeah. So the
Please,
conventional surgery is taking the trapezium out, and that gets rid of the joint, but it also gets rid of the other parts of the joint. So the trapezium itself, as you know, articulates not only with the metacarpal, but it also articulates with the scaphoid, and it articulates with the trapezoid, and also with the second metacarpal. And in my practice, or in my experience, in the older patient who comes to you with CMCJ arthritis, many of them have significant STT arthritis as well, which is arthritis at the scapho, trapezium, trapezoid, and to some extent, the trapezium metacarpal joint. And for these people, taking the trapezium out is great because you get rid of the trapezium. The pain is gone not only at the CMCJ, but also the pain at those other joints, which may be there at the time or which may be going on to progress. So that's great from a trapeziumectomy point of view. Problem with doing a trapeziectomy, obviously, is that it's a relatively big bone in that area, and you can get collapse of the thumb metacarpal. You get a reconfiguration of the pull of the tendon, so you can get a Z deformity. You also get some degree of weakness, especially with the pinch between the thumb index and middle fingers. Now, to try to address that and to sort of replace, to some extent, like with like, there's the concept of doing a partial trapeziumectomy. So taking the distal bit of the trapezium out, so essentially getting rid of the CMCJ, and then either putting an interpositional tissue in there, like pyrocarbon, or actually putting in a joint replacement, like a mini hip, if you will. Okay, so the concept there is, because you're not taking the trapezium out completely, you have a more stable situation, so there isn't a collapse, and you don't have the thumb weakness that can be seen after trapeziumectomy. So that's the reason for the joint replacement, whether you're using an interpositional joint replacement or an actual, like a mini hip type replacement. Now, we discussed the benefits of a trapeziumectomy, which is you get rid of pain. Okay. The other benefit is that actually It is a tried and tested procedure and has been done for decades. It really gives you pain relief excellently. And the number of times you have to go and revise the operation is very small. However, traditionally, what people have done is said that once you take the trapezium out, we want to try to stabilize the thumb metacarpal, and that's where the suspensoplasty comes in. And we can discuss the different types of suspension procedures if you want.
Yeah, that'd be really good. I mean, one of them obviously is LRTI, and I think that's something that historically was done much more frequently than perhaps it is today. And I know that some of the evidence basis for that nowadays is not as good as perhaps it was originally thought to be. With regards to LRTI, what do you tend to do, and if you ever do it, why?
So when I trained and then I became a consultant, that's 20 years ago, everybody who had a thumb CMCJ osteoarthritis requiring surgery would have a trapeziumectomy, which is a total trapeziumectomy, and have an LRTI using a slip of the FCR tendon. That's what I was taught, and that's what I did. But the evidence, and there's a huge body of work from Professor Tim Davis, which showed that the LRTI is not particularly helpful in most cases. So the LRTI is supposed to stabilize the thumb MCPJ from dorsal subluxation, and also the TI, which is a tendon interposition, gives you something to put in between the metacarpal and the scaphoid, so essentially taking up the space left behind by the trapezium to decrease the element of collapse. However, Professor Davis's work showed that you don't need to do either the LR bit or the TI bit to get very similar results. Now, less than 10% of my cases where I've done trapeziumectomy will actually have an LRTI. So since then, other suspension procedures have come about. And for people who are doing suspension procedures, you can have the APL sling, which is essentially taking a part of one of the slips of the abductor pollicis longus and using that for the suspension procedure as well as a tendon interposition.
Okay.
Some people quite like using a tightrope suspensoplasty, which is essentially using a non-absorbable material and attaching the base of the first metacarpal to the base of the second metacarpal in an effort to stabilize it to these two structures together. So there are suspensoplasties out there, but the evidence really now is that doing the suspensoplasty, whichever one, is not recommended as a primary procedure. If I do a trapeziumectomy and I find that the joint is very unstable, I might go ahead and do one of the suspensoplasties, or do it as a revision if I find out that I've done a trapeziumectomy and years down the line the patient's complaining of a collapse or some degree of instability of the joint.
I want to move on now to partial trapeziumectomies and joint replacements. In your opinion, what are the advantages and disadvantages of that approach?
Yes, this is very much something that comes and goes along with every new joint replacement that comes in. The most current one is something called the touch. Essentially, let's divide it into two kinds. So there's one that is essentially an interface. So you take a bit of the trapezium out and you slip a bit of material between the trapezium, the distal part of the trapezium, and the base of the metacarpal. And that allows that interface to keep the two bones apart. You've got rid of the joint. So that's how that works. What that does not necessarily do is to give you the level of stability that you're wanting to get. So people then go on to say, well, actually, why don't we put in something like a mini hip joint? And the concept behind this is that if you look at the thumb CMCJ movement, it's a very circumduction movement, not unlike a hip. So the hip joint type replacement is a stem that is put into the base of the metacarpal with a ball at the end of it. And then you take a bit of the trapezium off, create a concavity, and essentially put a cup into it. So you have a cup and ball effect. And this is stabilized by the soft tissues around it. The great advantage, and the studies have shown this, you get recovery over a shorter period than a trapeziumectomy because it's a much less invasive operation than taking the whole trapezium out. The other great advantage is that you retain the length of the thumb, so you don't get the Z deformities. And of course, the pinch grip is better than when you do a trapeziumectomy. there are disadvantages to this. And the disadvantages are, we discussed the STT arthritis. So this only addresses thumb CMCJ arthritis. And if that's the situation, that's a great operation. The other disadvantage, especially of the little mini hip joint prosthesis, is subluxation or even dislocation, and then leading on to revision surgery. So the frequency of revision surgery after partial trapeziectomy and joint replacement is significantly higher than revision surgery after trapeziectomy. And part of the revision surgery is because of failure of the implant, as we discussed, subluxation or even breakage of the implant, or the STT arthritis symptomology starting to become more manifest, and then people go and have that. So there are pluses and minuses, and you've got to pick your patient. There are studies. Now, I've got to put in the caveat that the studies that are out there looking at trapeziectomy plus or minus LRTI versus joint replacement aren't robust enough to make brilliant conclusions, in fairness. And that's why it's still a bit of contention. And there are some studies that show that at about a year post-op, the satisfaction from the operation is not particularly different between the patients who had a trapeziectomy versus someone who's had a joint replacement. However, if you look at pinch grip, the pinch grip certainly is better in patients who've had joint replacement. That doesn't necessarily translate into better hand function. That's why the satisfaction level is not necessarily any better.
Interesting.
So the pinch grip is very much an objective test of actually gripping, but does that actually translate into improved function in activities of daily living, which is measured by, like the Michigan Dash score and such like, which shows no particular difference.
And so focusing in on that, are there any particular situations where you'd be more likely to consider a joint replacement maybe of benefit?
Yeah, so I think, first of all, you've got to discuss the benefits, the disbenefits, the possible potential complications with the patients, and let them make a decision. Okay.
Sure.
And which operation you do, well, obviously, if you think there's an STT arthritis, then you cannot do the partial trapeziectomy. That's obvious. Diagnosing that may be a bit more difficult than you think. Certainly clinically you can't diagnose STT versus just CMCJ. Radiographs may not be helpful, and sometimes even CT scans may not be particularly helpful regarding this. And there's times when you go to do a joint replacement and you get in there and you realize that there's a bit more STT arthritis than you thought. The second thing is that, remember, the bone itself is being destroyed, and sometimes you get in and the trapezium itself is not robust enough, not strong enough to be able to sit a cup properly. So then you say, well, I'll need to go and do a trapeziectomy. But generally, if you rule these situations out, you've got to look at the functional demand of the hand. So if you've got someone who's got a low functional demand of the hand, meaning, they're essentially puttering around the house, puttering around the garden, a trapeziectomy is great for them, low revision surgery, and the evidence is that they manage very well with it. But if you've got someone with a higher demand function of the hand, where they're doing stuff, for example, you've got a brickie who got a Bennett's fracture, which did not heal properly and has osteoarthritis, only at the CMCJ, but has a very high level demand in terms of the hand, they would be a much better candidate. So it's a very bespoke thing, and you've got to, like all operations, for the correct indication, each operation definitely has its merits.
Sure. A couple of other things I've read about that can be used, according to the textbooks at least, is arthrodesis, so fusing the joint, and denervation procedures. And I wonder if you've got any particular experience of either of those?
So I don't have any experience doing denervation as the only procedure. Obviously, there's some degree of denervation that occurs when you're going and doing a trapeziectomy or partial trapeziectomy, but I have not gone in to try to just denervate and leave the rest of the infrastructure as it is. So I don't feel that I should be making much comment on that.
Sure, okay.
Joint fusion, however, now you've got to understand that if you look at the thumb, it's got three joints, the IPJ, the MCPJ, and the CMCJ. And if you fuse the IPJ and the MCPJ, the thumb's still very useful because the CMCJ is where all the movement happens. So if you're fusing the thumb CMCJ, you're actually defunctioning the thumb in terms of reducing its movement significantly. So in my opinion, the only time I would actually do a thumb CMCJ fusion is as a salvage procedure.
Right.
And in those situations, the trapezium is gone and the patient has, for instance, gross instability, and they still continue to get pain, then you may go on to do a fusion. But number of times I've done a CMCJ fusion, I can count on the digits of my hand.
Sure. And so just to try and bring all of this together, I guess, we've talked about a lot of different management options. Are there any particular factors that may affect what approach you recommend for a particular patient, or?
I think, Matt, for all patients, but most definitely hand patients, I think what we need to do as surgeons is explain to them the management options in as much detail as we can, and really get them to make a decision. The empowering of the patient is terribly important, because sometimes it's very difficult for us to actually understand what they use their hand for and what they need to do with their hand.
Yeah.
Having said that, as well as I do, that many times the patients will say, well, what do you suggest, doctor? And I think it all, assuming that the patient's well enough to have any surgical procedure, and if you're limiting ourselves to surgical procedures, then I would use the demand expectations of the hand from the patient as my indicator as to which procedure would be best for them. But always give them the caveat that once we actually intraoperatively, the findings may be different and we may need to go from one procedure to another if the findings don't correlate with the imaging that we've seen.
Brilliant. Some really interesting points there, and that's really helped demystify some things for me. It just remains for me to thank our speaker, Mr. Majumder, for sharing his knowledge and experience. Thank you.
Thanks very much, Matt. I quite enjoyed that. Yes, I hope that has clarified the topic somewhat for the trainees, but I would add the caveat that these are my opinions. And as I urge all my trainees, I would say go and seek other points of view, and don't take my point of view as gospel. Read the literature and allow yourselves to be guided by robust evidence where indeed this exists.
Some good advice for any topic there, I think. And thank you to everyone listening. I hope that's been enjoyable and useful, and if it has, do check out some of our other content. Goodbye. Podplast UK is a collaboration between UK plastic surgery trainees and consultants. The content reflects individuals' practice and opinions may vary. If you have any feedback, do get in touch. We hope that this has been interesting and useful. If it has, remember to follow us for future sessions.